Hello everybody, this is Dr. Ashur. Today we are going to continue our series of videos about drugs in inflammatory bowel disease. In the previous video we talked about the pathophysiology of this disease and the first class used for its treatment, which is the mesalamine based therapy. Today we are going to continue the series of therapies for this disease, which include glucocorticoids, immunosuppressive agents, anti-TNF alpha therapy, in addition to antibiotics and probiotics. So, glucocorticoids, we know glucocorticoids, from the kidney, there is glucocorticoids, there is mineralocorticoids, right? So, glucocorticoids are carbohydrate regulating steroids produced by the adrenal cortex, okay? They are used for so many inflammatory and for diseases and as immune suppressant as well. So here they are used only for moderate to severe inflammatory bowel disease. We know they have a big profile of side effects, okay, including but not limited to osteoporosis, continued use may lead to diabetes, peptic ulcer, you name it. So many side effects. We can use them just for moderate to severe disease. So we have now the previous class, okay, just as a reminder, we have the mesalamines. These are the first choice, okay, least side effect, they are first choice, okay. So then the glucocorticoids comes when there is a failure or the patient is not responding to the mesalamines. So they are indicated only for moderate to severe IBD. In GIT-related diseases, prednisone and prednisolone are the most commonly used oral glucocorticoids, okay? Prednisone, okay, and when it is metabolized, the active metabolite is prednisolone, metabolized in the liver. The active metabolite is prednisolone. Okay, both are effective in treatment of IBD. These drugs have intermediate, they have kind of little bit long duration of action, relatively, so they can be used only once daily. To prevent against the multiple side effects we just talked about and many other of the corticosteroids, we can prescribe these medications just local. Do you remember mesalamine? Okay, we talked about Roasa, Canasa, and these the enema and suppository, right? Here also we can use hydrocortisone, which is the natural glucocorticoids, also called cortisol, okay. It could be used as enemas or suppositories to maximize colonic tissue effect. So much dose is going to the target, okay, and minimize the systemic absorption, even though about 15 to 30% may be absorbed, okay. But this will be relatively much less than when you give the drug orally from the beginning, okay. So this could be prescribed for patients with IBD in the rectum or sigmoid colon, okay, so way down at the end or distal. Okay, the response of patient to steroids in individual patients with IBD divides them into three categories. So these patients are divided into three categories. The name will help you a lot, okay. The name is kind of speaking to you. Say like, please, I'm here. Just look at the name. The name will tell you what's this class represent, okay. So steroid responsive, just without saying anything, steroid responsive means it responds to glucocorticoids. So patients, about 40% of patients improve clinically, generally within 1 or 2 weeks, so very quick response, and also they remain in remission as the steroid is tapered, then discontinued. When we stop the glucocorticoids, you don't stop them abruptly, okay, otherwise the patients who have glucocorticoid withdrawal symptoms, nausea, vomiting, diarrhea, joint pain, so several issues, okay. So you need to taper them. Taper them means to give the dose. If you are giving 2 tablets 3 times a day for like 1 week, and then you give 1 tablet 3 times a day, then you give 1 tablet 2 times a day, and then 1, and so forth. Okay, so you go maybe half tablet and so forth until you stop the glucocorticoid completely. At that time, you'll give a time for the endogenous mechanism of production of glucocorticoid, of producing hydrocortisone in the body from the adrenal cortex. So give them some time until they regain their activity. Before they were lazy, right? Because they are giving corticosteroid from outside, right? Then they will regain their activity, and then you'll have no problem, generally speaking. The second class is steroid dependent. The name again says something without we look at anything. Dependent, so means whenever you give them, they are okay. You stop, they start have a relapse. Okay, so patient also respond, but they experience relapse of symptoms as the steroid dose is tapered. Okay, when you just taper the dose, the disease relapse means comes again. The last class, again the name says it. Okay, so steroid unresponsive. Okay, about 50 to 20% patients don't improve even with prolonged high dose steroids. Okay. Mechanism of action. Okay, so many mechanisms of action. Number 1, inhibit production of inflammatory cytokines such as TNF alpha, interleukin 1, and the chemokine IL-8. Okay, it's chemo-attracting, attract the neutrophils and leukocytes, generally speaking, to the site of inflammation. Number 2, reduce expression of inflammatory cell adhesion molecules, inhibit gene expression of nitric oxide synthase NOS. Okay, phospholipase E2, this is a very important mechanism. We'll see it in the next slide. COX-2, lipoxygenase. COX-2 is responsible for the production of prostaglandin. Lipoxygenase is responsible for the production of leukotrienes and lipoxins, hydroxyicosahexatetraenoic acid, and many. And NF-kappa, which is a transcription factor responsible for the production of many inflammatory mediators. Okay, so here one is one of the mechanisms. This is the cell membrane. Okay, cell membrane contains phospholipids. The enzyme phospholipase act on this phospholipids to liberate arachidonic acid, AA. Okay, arachidonic acid. And this arachidonic acid could be substrate of COX or LOX. Okay, COX will produce, as I said, prostaglandin, prostacyclin, thromboxane. Lipoxygenase will be the source of production of hydroxyicosahexatetraenoic acid, which is a precursor for leukotrienes and lipoxins and many inflammatory mediators. So here, corticosteroids, stop, the mechanism way in the, in the beginning, right? Up there. Okay? So they inhibit phospholipase E2. You can imagine everything here will stop. And also they can inhibit COX. Also you can inhibit LOX also. So they are very, very important. Okay? This is just the class of non-steroidal anti-inflammatory drugs only inhibit COX, these classes such as aspirin, ibuprofen, diclofenac, piroxicam, and others. But this is the main class we're talking about, which is the corticosteroids. It's corticosteroid, yes. Corticosteroid, includes mineralocorticoid and the glucocorticoids, right? But generally speaking, when we say corticosteroids, we mean glucocorticoids. Okay, please take it like that. Even so many books, they talk about it like that. So corticosteroids, we mean. Exactly, if you need by the book, corticosteroids includes glucocorticoids and mineralocorticoids. So, they induce remission in the majority of patients. They are very efficient with either ulcerative colitis or Crohn's disease. They are not effective in maintaining remission. You remember there when you talked about sulfasalazine, mesalamines, we say they can maintain remission. Okay, here they can induce remission, but they don't maintain remission, means the patient can relapse. Okay, oral prednisone is the preferred agent for moderate to severe cases. Typical dose 40 to 60 milligram once a day, as we said, some long duration of action. High doses are not more effective, so just limited to 40 to 60 milligram once a day. The glucocorticoid dose of IBD is tapered over weeks to months. Okay, 2 months. So you go, decrease the dose gradually, as I said, to give a chance for the endogenous mechanism to produce the glucocorticoid. So even with tapering the dose, you have to exert your so much effort to reduce the use of these drugs and the duration of these drugs because of their side effects. Sorry. For more severe cases, steroids such as methylprednisolone and hydrocortisone, these could be given IV, intravenously, so they can have so much, rapid effect and very efficient. The next class is immunosuppressive agents. Okay, many agents developed in the beginning just to treat cancer, or they deal with autoimmune disease. Okay, they have shown efficacy also for treatment of IBD, inflammatory bowel disease. Okay, but side effect profile is still there. You have to very careful. Okay, both real and potential side effects mandate careful assessment of potential risk and benefits in each patient. So this class comes third: mesalamine, glucocorticoids, immune suppressive agents. Okay. While the initial use for IBD was based on the immunosuppressive effect, the mechanism is not well known. Okay, so the individual drugs include azathioprine, methotrexate, cyclosporin. Okay, these are drugs like that, as we said, mainly they are this methotrexate, azathioprine, mainly anti-cancer agent, cyclosporin, mainly immune suppressive agent. Also, all of these drugs are immune suppressive agents. They are reserved for patients whose IBD is either steroid resistant or steroid dependent. Remember the three classes? So the second or third class. Okay, so you reserve them. So now again, mesalamine number one, glucocorticoids, then immune suppressive agents. Azathioprine is used in the induction and maintenance of both. Please remember, because the other drugs will have just individual effects. Maintenance of remission of ulcerative colitis. Okay, induction of remission of ulcerative colitis and Crohn's disease, both. Okay. However, methotrexate is used to induce and maintain remission in patients with Crohn's disease. Okay, its efficacy in ulcerative colitis is uncertain. Okay, what's remaining here is ulcerative colitis, right? Ulcerative colitis here. Cyclosporin is effective in patients with severe ulcerative colitis who have failed to respond adequately to glucocorticoid therapy. Okay. Mechanism of action, quickly, because we already talked about these in different classes in anti-cancers and immune suppressive agents. So quickly, azathioprine is anti-metabolite. Anti-metabolite means it resembles something in the body and it tricks certain enzyme. Okay, how this happens? It's anti-metabolite which impairs purine biosynthesis. Purines include adenine and guanine, right? And inhibits cell proliferation. It's a prodrug converted into mercaptopurine. Okay, mercaptopurine. Okay. Thio means it's sulfur. Mercapto also means it's sulfur. Okay, or sulfur hydryl group. Mercaptopurine, which is subsequently metabolized to 6-thio have sulfur group in the guanine. So the guanine nucleotide, which is required for the DNA replication, okay, is there, but you add just one sulfur group at position 6. Okay. This will trick the DNA polymerase, okay? It will take it and then it will stop. So it will stop the replication and inhibit the cell activity and cause cell death. Methotrexate antimetabolite is folic acid analog. It's well known, okay? Folic acid analog, and it's the main folate antagonist, okay? Folic acid, okay, is metabolized into dihydrofolic acid, then tetrahydrofolic acid, which is the active form that can work as methyl donor, okay, from uracil. If you add methyl group to uracil, okay, it will be thymine, okay. So from RNA to DNA, okay. So if you inhibit this, you inhibit DNA synthesis. So they inhibit the hydrofolate reductase, thereby blocking DNA synthesis and causing cell death. This is methotrexate. Okay, the third guy is the cyclosporin. Cyclosporin, okay, is from a class called calcineurin inhibitors. Okay, calcineurin inhibitors. It's a potent immunomodulator. It's used for organ transplantation as immunosuppressive agent. Okay, as we said, calcineurin, right? Calcineurin inhibitor, right? So what's calcineurin? Calcineurin is a phosphatase. Okay. That dephosphorylated, so this is the NFAT, nuclear factor of activated T cells. It's phosphorylated. It needs to be dephosphorylated to be able to enter into the nucleus and simulate the transcription of interleukin 2 and other cytokines to stimulate immune response. So this is the NFAT, okay? So if I use cyclosporin and other calcineurin inhibitors, they work by inhibiting calcineurin, okay? They inhibit this calcineurin. So now this cyclosporin, it will bind to its partner in the cytoplasm called cyclophilin. This complex will inhibit the calcineurin. So now I'm inhibiting the dephosphorylation NFAT. So this NFAT will stay like that, cannot go into the nucleus. It cannot go to induce the activation of T lymphocytes. Okay, this will result in subsequent suppression of humoral and cell-mediated immune responses. Okay, the second class is the anti-TNF therapy. We said TNF-alpha is one of the most important cytokines that can induce the Crohn's disease specifically. Okay, so they developed this antibody, the chimeric immunoglobulin Infliximab, okay, which bind to and neutralize TNF-alpha, tumor necrosis factor alpha. It's a new class of therapeutic agents for treating IBD. It's very expensive too. Although many cytokines are generated in the inflamed gut of in IBD patients, there is a rationale for targeting TNF-alpha. Why specifically TNF-alpha? There is IL-1, there is IL-2, there is other cytokines. So why TNF-alpha? It's one of the principal cytokines mediating Th1 immune response characteristic of Crohn's disease. Please remember this. Th1 can induce Crohn's disease. Okay. Th2 is responsible for ulcerative colitis. Of course, if something wrong happened with these two immune responses. Okay. Infliximab binds to TNF-alpha with high affinity. Okay, and prevent it from binding to its receptor. Easy, right? So TNF-alpha would like to bind to TNF-alpha receptors, okay, to induce its effect. This will bind it and prevent it from binding to the receptors. It also binds to membrane. There is cytoplasmic TNF-alpha and there is membrane-bound TNF-alpha. The membrane-bound TNF-alpha that infliximab can bind to it and may cause lysis of the cells by antibody-dependent and cell-mediated cytotoxicity. Okay, so here's this diagram shows the proposed pathogenesis of IBD and target sites for pharmacological interventions. We'll focus here only. So just a quick recap. Okay, so this is the bacteria. Okay, bacteria, when there is impairment of the barrier function of the epithelium here, bacteria can gain access into the cytoplasm. So they can give their antigen. Antigen will be uptaken by the dendritic cells. One of the most, it's the most important actually, the professional antigen presenting cells, which will present this antigen into the T helper cells. Okay, this will activate T helper cells, which will produce interferon gamma, IL-2. This can activate Th1 cell response, okay, or immune response. Th1 responsible for Crohn's disease. So Th1 will produce also cytokines such as TNF-alpha, interferon gamma, which activate macrophage. Macrophage also will produce the same two cytokines to activate also the TNF, the Th1 cell immune response. Okay, so they activate each other. This activate this and this activate this. Okay. The other pathway, just as a quick recap, the Th2 itself can induce ulcerative colitis. Okay. But we are talking about infliximab, which is anti-TNF-alpha. It will inhibit TNF-alpha here from binding to its receptors. And as we mentioned before, it will inhibit this cycle of events, okay? And it will help in treatment of Crohn's disease. Okay? Decrease the frequency of acute flares of Crohn's disease and facilitates the closing of cutaneous fistula. We said Crohn's disease is transmural, right? It can pass all the layers of the affected GIT organ, right? All the layers, right? So it can even cause fistula, okay? So it can treat this, dose 5 milligram per kg intravenously at interval of several weeks to months. It's efficacious in maintaining remission and preventing recurrence and of fistulas, very efficient. Okay, combination of infliximab, the anti-TNF-alpha, and the azathioprine, the immunosuppressive agent, which is antimetabolite, is more effective than infliximab alone in induction of remission and mucosal healing of steroid-resistant patients. Okay, it's effective also treatment for refractive ulcerative colitis also. But the main use is for Crohn's disease. Okay, adverse effects like hypersensitivity-like reactions such as fever, chills, urticaria, even anaphylactic shock, and subacute reactions may develop after infliximab infusion. Is associated with increased incidence of respiratory infections such as TB. It's contraindicated in severe congestive heart failure. We'll explain this later in our next video. Antibodies to infliximab can decrease its clinical efficacy. You're injecting this guy, but body can develop antibodies to it. So how can you minimize this one? Okay, either treatment with glucocorticoids, okay, or immunosuppressive agents, as we said, as a thioprine, okay, can preserve infliximab efficacy. Also increasing the dose or decreasing the interval. We said could be used over weeks or months. Okay, you can decrease the interval instead of maybe 4 weeks, you make it every 3 weeks, and so this can overcome the problem of antibody resistance. Okay. Then the last two classes, antibiotics and probiotics. Okay, generally speaking, chronic bacteria may either initiate or perpetuate the inflammation of IBD. Okay, so recent studies have implicated specific bacterial antigens in the pathogenesis of Crohn's disease. We are talking about here, there is a microbiome and there is some pathogens, pathogenic bacteria. We're talking about the pathogenic bacteria here. Okay, this prompt attempts to manipulate chronic bacteria flora in patients with IBD by mainly antibiotics. Okay, which could be used either as adjunct treatment along with other medications for active IBD such as mesalamine, glucocorticoids, and other. Treatment for a specific complication of Crohn's disease that necessitates use of antibiotics. Prophylaxis for recurrence in post-operative Crohn's disease. Okay. Examples: metronidazole, inhibition of nucleic acid synthesis. Ciprofloxacin is a quinolone, inhibits DNA gyrase or topoisomerase. Clarithromycin inhibits protein synthesis. Okay. These are the most commonly used guys. Okay. Probiotics. Okay. Generally speaking, Crohn's disease is a chronic inflammatory disorder in the GIT in which the pathogen is believed to be partly influenced by the gut microbiome. Okay. So you need to manipulate, you need to repair the gut microbiome. Okay. So probiotics such as yogurt, just the simple one is yogurt. Okay, yogurt you get from the store. Okay, the mixture of putatively beneficial lyophilized bacteria given orally. Probiotics can be used to manipulate the microbiome. Okay, and have therefore be considered as potential therapy for IBD. Okay, they showed some promise in irritable bowel syndrome. However, their efficacy in either Crohn's disease, ulcerative colitis is not clear yet. Okay, it's not confirmed yet exactly. So it needs some further investigation. Okay. Finally, supportive therapy. Okay, now the patient has diarrhea, has colic, and other things. You can deal with it by analgesic, anticholinergic, and diarrheal agents. Okay, so to improve the symptoms and quality of life. Such as loperamide and diphenhydroxylates. Okay, these are opioid drugs. They decrease the motility of the GIT, so they decrease frequency of bowel movement in mild to moderate severe cases of diarrhea. Anticholinergic agents to deal with the colic and also may help also with the diarrhea, such as dicyclomine hydrochloride to reduce abdominal cramps, pains, and rectal urgency. Okay. That's it for now. Thank you for attention, and I'll see you soon in trying to find other natural remedies for treatment of inflammatory bowel disease. Until then, I hope you enjoy your life, okay, and see you soon, inshallah.